Good afternoon, everyone. Welcome to RUInformed. RUInformed is a part of our lifelong learning platform for Retirement Unlimited Incorporated. We like to provide our actual resources to all of the entire community, as well as our residents and families. Today, we'd like to introduce our guest, Mark Cifarelli, who has a master's in physical therapy, and he works for Legacy Healthcare Services. He's been there since 2010. His current role is a director of clinical practice. He is responsible for overseeing the quality of the clinical content of all of Legacy Healthcare programs. Mark, we are going to give our time and attention to you. Thank you for joining us today. We're looking forward to talk about the topic of low vision awareness and solutions. Mark, thank you.
Well, thank you. I appreciate that. And I'm happy to be here and hopefully share some useful information for you. Um, as Dr. Kidd has mentioned, I am a physical therapist and I've been doing that for about 31 years. And the reality is that low vision isn't really part of a physical therapy practice. However, having worked for um, almost 16 years now for Legacy and having worked in multiple other settings, I've had the opportunity to be exposed to a lot of instruction and information and knowledge of coworkers that does revolve around this. We work with a lot, we employ a lot of occupational therapists, and this does fall well within their scope of practice. And so, one of the things that I've taken on as part of my role is to making sure that they are up to speed with what they can do in order to be able to help residents of the buildings that we serve when they have low vision issues, as well as obviously many others. So, to get started, let's just talk about, what is low vision? Because low vision does not mean obviously blindness. There's a large range that can occur before that. Myself, I just turned 60, which is a frightening thought in my own head, but I technically have low vision. I've had low vision most of my life. I wear contacts, and in the last 10 years, have started wearing reading glasses and all of those kinds of things. So, um, technically, I fall on the hopefully the far end, of that spectrum. But National Institute will talk about low vision, visual impairment, but really they only talk about it when it's severe enough to interfere with the performance of daily activities. Um, Vision has been lost that can't be regained. It can be adjusted for, it can be compensated for, but the vision is not going to return. And that's really where low vision's, definition lies. There's a lot of different things that can come into this. There's a lot of different diagnoses that are part of it. You can have just a central visual loss. You can have peripheral visual loss, and that comes from a couple of different things. Um, Night blindness, reduced contrast sensitivity, glare sensitivity, and I really think that last one is a big, big issue for a lot of the population that we work with currently in the older population. As they age, their retinas and lenses are not able to really filter that glare as well as they used to. And so that really can impact their vision, even when they have quote unquote normal vision or not really classified as low vision. They may still have a lot of difficulty navigating and handling things because of the glare that they're not able to separate. So it kind of interferes with their ability to see what they're doing. Um, what we're going to talk about a little bit is some cataracts because those are very, very common in the patient population. That age-related macular degeneration that we always hear about. Diabetic retinopathy comes in a little bit, and we'll also see some glaucoma. But the prevalence is really quite high. 25% of people 65 years or older experience low vision. And that is, again, low vision defined as being severe enough to interfere with their abilities to perform their daily activities, right? Um, this number will probably increase with the baby boomers on the rise. as they're hitting those older years. I always tell people, if my kids go, "Oh, you're such a boomer," and I go, "Well, yeah, I am, because I'm actually right at the end of that time frame for the baby boomers." So I'm a boomer. I am proud of it. But we're talking about by 2030, about 7.7 million Americans will be impacted by low vision. Now, you start looking at numbers more specifically for other things. You have cataracts. Currently in the US, 25 million people will be suffering from cataracts, 19.8 million with macular degeneration, and 9.6 million with diabetic retinopathy, which accounts for, I believe, somewhere around 25 to 30% of people with diabetes. Obviously, you have to have diabetes to have diabetic retinopathy, right? The third leading cause of disability in the US for people 75 years and older. I'm going to assume that many of the people in our communities that we serve fall within that age bracket, right? There may be a few younger, but probably 75 and above, right? Now, the nursing home residents, that's more long-term care. So maybe not 66% of the folks in our buildings, but certainly that number is impactful. So let's talk about vision loss. All right. And what I have here are a number of little videos. Don't worry, there's no sound with these videos, so don't feel like there's anything you need to adjust. That just kind of go through what it would be like to have some of these visual complications, if you will. This it's kind of, I don't want to say fun, maybe fun is an interesting way to put this, but we've done this in some of our clinics every once in a while with facility staff to give them that experience. And sometimes what we'll do is we'll take just regular goggles, like you would wear safety goggles, right? Back in the day when you were doing high school chemistry, and just smear the lenses with Vaseline and then have them try to perform a task. Here, make a sandwich, or, do this, something. And just the difficulty that people will have. It can be kind of amusing, but it's also very insightful. So I don't have the ability to give you all goggles right now, but looking at, just normal vision, right? Walking down a hall that probably looks this is not any of your halls, by the way, but just happens to be a hallway. Um, Pretty straightforward, pretty simple. What we're going to get to, though, a little bit later on is we're going to talk about how this exact image here is going to be affected even through cognitive loss. Okay. So moving on from that, that's probably pretty straightforward, right? But what does it look like when somebody has cataracts? Okay. You're going to have a lot of blurred vision, but you're also going to have a lot more glare. Okay, so the ability to now see through those cataracts, remember, that's a film that's actually covering, it's underneath the lens, it's over the eye, and you have to see through it. Okay, so when you do that, you have to kind of work a little bit harder to notice what's going on. But look at just the end of the hallway, right? Before, in the prior video, okay, you had light coming in through the window and the door, right? Now, kind of look at that. It's like that blur, that brightness, right? That's the glare that can get worse. So when you have cataracts, you still have to be able to maneuver around obstacles, right? So looking at the stairs, right? Now, you look down at those stairs, you've got the glare, and as you get closer, it almost becomes more difficult to be able to discern where the step is. Okay, so we want people to, okay, come on, let's go, let's get up the stairs, right? That may be very difficult for them to be able to manage that because they can't really see where the step is, right? There's kind of a darker line. Sometimes they think the darker line is the step, but that's really the riser. And then that glare coming into play as well can be very difficult for them to be able to discern where they're supposed to put their foot for safety. And you say, well, our residents, they all take the elevator, right? We don't worry about taking the stairs. One of the things that I've always talked about with our therapists and other folks is the safety concern if someone is not able to navigate stairs. There was tragically recently a fire up north in Massachusetts, I think it was, at an assisted living facility, and all of the residents had to wait to be evacuated, right? And I believe most got out safely, thankfully, but in a large community, if there aren't any people that can navigate the stairs and they're all still waiting for the elevator, that becomes a big safety concern, right? So being able to help people navigate that can be really important. Now, cataracts can get much worse. This is severe cataracts, right? Being able to see that. This is the exact same hallway, by the way, and the exact same image. Trying to walk past that table that was there in the hallway, right? Coming down to the end of the hall and seeing the light from the windows, much brighter, much more difficult to be able to process what's going on with that. All right. Now, interestingly, when it comes to cataracts, and they don't usually let people go this long, but I actually had a dog that had really bad cataracts, but they didn't, he was very old at the same time. They did want to do surgery. I mean, look at those stairs. You can barely see them, right? Um, what happened was they actually got so bad that they cracked the cataracts themselves because it's not really calcium deposit. It's always easy for me to think about it that way. They're kind of a hard substance and they actually cracked, and the dog was actually able to see between the cracks of the cataract to be able to navigate fine. But that being said, he didn't have to make his own meals. He didn't have to, clean up. He didn't have to vacuum. He didn't have to drive. My dog's never done that. Um, so that's kind of the difficulty when it comes to cataracts. Now, macular degeneration has a very different presentation than that. All right. Macular degeneration will degenerate the macula, which is kind of where that visual spot is to be able to see straight ahead. So now there's basically this black spot that is right in the middle of their vision, right? So now here's a person you run across in the hallway, but you can't see their face. All right. So you're not really sure who it is. So how is this person going to react if you just kind of walk up to them, and start talking, right? They may not be able to see who you are because they just can't recognize you. All right. Because they can't really see your face. Things that can be done a little bit with this, because again, this is a visual loss that will not return. Um, you teach them how to kind of look to the sides of the visual loss. So it's very difficult and it takes training because every time you turn to look at what it is you want to look at, you're putting the black spot in the way. So you actually have to train them to basically look away from what it is they want to be able to see. All right. And that can be very difficult for people, especially as they get older and again, as they have some cognitive loss. All right. So we've seen what that looks like. Unfortunately, we can't see through these residents' eyes, so we can't just automatically make the assessments. So we have to have a way to be able to test and say, what's going on here? What kind of problems are they having? Obviously, the classic one is the Snellen eye test, right? Believe it or not, that is what that's called. Dr. Snellen, I have no idea when, developed this. Um, We've all seen it. We've all been to the eye doctor and we've all had to read the bottom line, right? Better one or two, right? One or two. Believe it or not, this falls within an occupational therapist scope of practice to actually assess this. Okay, so they can do that. Now, they cannot diagnose what, corrective lens they need or something of that nature, but they can perform the assessment to at least determine that their vision is not 20/20 or 20/40 like it used to be. So there are a lot of other things that we can use for assessment. But one of the things that we will use in a practical sense is this what's called a PEO model, person, occupation, environment. Basically looking at this as a total inclusive for this person, right? What's going on with this person? What do they need to be able to do? Because remember, low vision is defined by interfering with their ability to perform their daily activities, right? Um, I will say this because this always kind of is a sticking point. My wife's an occupational therapist, and I always tell her that her profession is misnamed. You tell a lot of these older people in these facilities like, oh, it's an occupational therapy. I retired years ago. I don't need that, right? They can work on job, but mostly what they work on, and the way that my wife has always said it is, they work on whatever it is that occupies you throughout your day. That's the occupational part. What are you occupied by? Which means ADLs, IADLs, all those kinds of things. So when we look at this particular model, we take into account the person because we do want to be, person centric when we are looking at someone's care, right? But what are the things that they need to be able to do, which includes what are the things they want to be able to do, right? That is an important component. It's that life experience we talk about where somebody has that socialization, that involvement, that kind of that joy in their life. What did they do and what do they want to be able to do so that they can have that? And then the environment in which they live in, right? In the midst of all of that, and this would be described as a Venn diagram. If you've ever had kids in school, they've come home and had to do a Venn diagram where they overlap, right? That is the center of participation and performance, right? That's described as yes, they can do it, but yes, they want to do it, right? Because there's a lot of things that people aren't interested that you know will fall within that occupation kind of part of things, but you know, will they want to do it? We talk a lot about that with our therapists as well, because that motivation component can be really, really important when we know people need to do certain things, but they're not interested in them. So how can we adjust those to be something they want to do, right? So with this particular model, if you will, you put all of those three things together and out comes your functional goals. Pardon me. Outcomes what it is you want to achieve, right? What is this person's interests and needs come down to, and can we approach those and do we need to adjust? Do we need to adjust the person in some way, which means maybe change their visual input in any way? Do we need to change their environment in some way? That we can adjust that. We're going to talk about different ways for this to happen, right? Is there something we can modify in what it is they want to be doing that will allow them to be successful with it? That can be really, really important as well. So, in an assessment, what we're going to look for, and we're going to start with an interview, is what are their concerns? What is it that they want to do? What do they prioritize, right? This is that, client-centered approach to things, right? What is their history, right? And it can be work history, maybe, right? There may be considerations in there that have affected their vision and how they function because of what they've done for a living, right? And how do they perform their things? So a lot of times this comes down to routines. Okay. They may have a certain role, maybe it's a spouse caring for their loved one, something of that nature, and they have habits and sometimes they're referred to as rituals, but a lot of times these are routines, especially in this patient population we find, and again, I'm going to touch on that cognitive component piece. When they get to a certain level, they rely on routines to be successful. If they've always done it a certain way and it's always worked, they're going to stick with that way. And a lot of times it's good, and we can encourage that and kind of work with that because it's going to make them successful, and we want them to be successful. All right. Um, as an aside, my mother, who never ended up in any kind of facility, and I say that I don't mean it in a bad way. She would have loved being in some of these communities because it would have been very engaging for her, and it probably would have been really good for her. But she insisted on staying at home in the house I grew up in. She lived there her whole life, but she had certain routines that would have made it difficult moving into another facility. If she ever had to go to an assisted living or certainly a skilled facility, um, she had certain routines that she did, and she would find it very disruptive to her lifestyle if she had to adapt to those. And she may have had a lot of difficulty doing so. So the routines can be really, really important for people. And then we need to know what their interests and their values are. What are they really valuing, right? What if you have somebody who's experiencing low vision, but they love to read? Now, that's a high value item that's going to be very difficult for them, but can we do something to help them with that, right? When you think about those things, though, one of the things I've always stressed is asking these individuals. Remember, they're an older population, right? They're even older than I am, okay? But there are there's a mentality that goes along with it. And I always think about my father when it comes to this, right? He would never complain about things. He would never just go to the doctor because he would, a lot of times they have given up things that they really want to do because they just don't think they can do them anymore. And when you ask them, what do you want to be able to do? They'll tell you some really basic, simple things that, are important. I want to be able to get to the dining room. I want to be able to, play bridge. I want to be, but they won't get into the deeper things that they really value because they think they're gone. They're gone. They're over. You can't do it anymore. Why bother bringing them up? So kind of asking that next step question of, is there anything that you have stopped doing that you'd love to be able to get back to doing? Right? That can make a huge difference in somebody's quality of life. Just that really simple question. Because a lot of times we'll get that in therapy and we'll ask that, well, I used to go to my daughter's house on Sunday for dinner, but I don't do that anymore. It's too hard. Well, you know what? I think we can get you back to being able to do that, and that is really motivational for people. We have occasionally had somebody say, well, I'd love to run another marathon. And you're like, well, maybe that's not realistic, but let's see if we can get you outside and walking and, those kinds of things. So we have to modulate a little bit of that. But some other things that we might do, we'll do an Allen cognitive level screen. That's we feel very important for what we do so that we don't just know what their cognition is. It's also how are we going to interact with that individual based on that level of cognition. When you know their level of cognition, you not only know will they be able to understand what I'm saying, but will they be able to remember it? And will they kind of internalize it because I presented it the right way? And that can be really important. A modified Barthel, if you're not familiar with that, it's basically an assessment of ADLs. How well do they brush their teeth, comb their hair, get dressed, those kinds of things. And we'll look at those things just to look at that occupation side of that equation. Um, this is basically just a similar kind of assessment that is more interview based. You may go through the caregiver. I'm not going to go into a lot of detail about this, but are they able to take their medications, correctly? That's really a big one for a lot of individuals. Do they really understand how frequently they need to take them? Do they need to be set up? And it's all graded and along those things. So, but really, when we come to the vision part, what we want to know is what is that impact on function? So we may do all of those assessments, but those assessments don't actually ask about vision. It's how much does vision interfere with your ability to do this? So that's something that we have to kind of look beyond those standardized tests for. Can they attend to a task long enough to complete it, or do they get headaches, dizzy? That can be a visual problem that comes up, right? What is the accuracy of how they're doing? Are they unable to do that test or task accurately because they can't really see, the totality of what they're doing, right? It takes number of trials, right? And how long, right? Sometimes just with low vision, they may just take longer to do it. And it's not necessarily a bad thing, but keeping track of that can a lot of times give you insight into, I think their vision's getting worse because they're taking longer now to do things, right? And as an example, think about dining, right? If they're eating a meal and it's on a plate and maybe they need, a spoon or a knife and fork, can they see what they're doing well enough to be able to eat at what you would term a normal pace? Or are they kind of trying to find the food for each bite and taking a lot longer in that process because they really can't see it, right? And we're going to get into talking about some of the things that can be done to help people with that. In that case, contrast can be really, really helpful, right? If you have kind of a, I don't know, beige colored food a beige or white plate because it's going to blend right in and they may not even know they were served anything, right? So that gets into some other complexities about, do you have multicolored plates and things like that in your facility? And that may not be the case. But are there ways to improve contrast to be able to see things? That other component of environment becomes really important because that's a way that we can enhance their low vision, that we can actually help them become more successful, right? So the very layout of their environment, right, their apartment or wherever it is that they're staying, is it conducive for them to be able to move around, be able to get to what they need to in an efficient manner without risk? Right? Is it cluttered? Do they have things that are in the way they could trip over? Um, do they, is the rug secured? Sometimes you have that hard surface and a throw rug over it because it looks nice. But is that something that they can trip over? And remember, even a very, very thin rug, a lot of these folks don't pick their feet up very high, and so they can easily just slide on them, those kinds of things. Um, Probably one of the biggest things again comes down to lighting. Obviously, vision relies on light, but having appropriate lighting, and that's really an important concept. Brighter is not always better. Remember the glare, right? What do the surfaces look like? Do they have a nice shiny floor for some reason in their facility? And probably a lot of carpeting, but um, maybe in the bathroom. Is it, a shiny surface and they're going to get a lot of glare because the light is too bright, right? Exciting these days. I mean, when I started many years ago, we didn't have LED bulbs, right? They were all incandescent, and you really just had a certain choice, a 40 watt, a 60 watt, a 100 watt. That was it. You want to make things brighter, you just put in a brighter bulb. Now, with the LEDs, we have the ability to adjust some of that lighting. You can actually make it brighter with a softer kind of light that doesn't create as much glare. I'm gonna geek out for a second. This was very exciting. It was at Home Depot. I had to get a new light bulb for our bathroom. We had one of those little vanity things that has three bulbs in it, and they actually have a bulb that I can not only set for, I think it was 50, 75, or 100 watt, compatibility because it's LED. It doesn't use that much wattage, but also for soft white, bright white, daylight, all the different. I mean, I could adjust that bulb in like 100 different ways. One bulb, just a switch right on the bulb. It's really kind of cool. Put it in, too bright, take it out, adjust it, put it back. That is really, really exciting. I know it sounds really kind of geeky of me, and I apologize, but it's really kind of exciting because we want to be able to provide the right light for these people without it creating that glare. And incandescent bulbs, if you're aware of this, right? Most lamps told you right on the lamp what the maximum wattage you could put in it was. And that's because incandescent bulbs get hot and it's a fire hazard. Well, LED lights don't really get hot. You can put in a much brighter wattage equivalent because it doesn't use the same wattage and it doesn't generate as much heat. So you can actually make that change and actually be able to brighten up somebody's environment. I go back to the individual who loves to read. Well, they love to read, but it's too dim. They can't. Well, now they can get a reading lamp right next to them with the best possible lighting for them. And that can really, pardon the pun, brighten someone's day. Um,
Those
so,
were great tips to have that you can do at home right now to make your environment safe and make it a good place for your vision. So thank you for those tips for home or in the community.
yeah, yeah, anywhere. Um, So looking at those kinds of things like reading, right? What are the demands of that? So what do they need to be able to do that? Where should they sit? How should the environment be created? I mean, and again, I'll stick with reading, right? They love to read in a particular chair. Well, the chair is right by the window, right? We can put a reading lamp right there But then sometimes at some times of the day, the light coming in through the window creates too much glare, and now they can't do that. So would it make more sense to put their chair in a different spot in their apartment with that reading lamp so that they could actually read it any time that they want? People get very particular about the layout of their apartments, and I understand that, but explaining why we want to, or suggesting to make that change, right? Because we're not going to tell them what they should and shouldn't do, but we can suggest and we can explain that may be beneficial for them, right? So looking at whatever it is that they need to do and then what they want to do as well, right? There are certain things they have to do. They need to get up and they need to get dressed and they need to perform their daily hygiene and all those kinds of things, right? But they also have things that they want to do and they should be able to do those. All right. So what are we going to do? Right? We've identified this person has low vision. They have these needs. They have these wants. What are we going to do? Well, obviously, first and foremost, could send them to get their eyes checked, right? That's not something therapy can do. It's not something we do. And I just threw this in here because, ophthalmologist versus an optometrist, right? Ophthalmologist is advanced. That's an MD. That's someone who is going to, potentially do cataract surgery or diagnose macular degeneration. Not that an optometrist couldn't do that. They'd probably follow up with an ophthalmologist to see what kind of interventions can be done, right? The optometrist is the one we're all very familiar with, right? It's the one that we go to every year to get our eyes checked, right? I've got a fantastic one here, found her by accident, and she's been absolutely amazing, right? If you're not happy with your provider, find a new one. All right. But that's just kind of the difference with that. But we should always make sure, and it's routine, right? And a lot of these people, yeah, maybe once a year is fine, like everybody else, but maybe they're going through some changes that are happening more rapidly, and maybe they need to be seen more frequently than that. But I can't tell you how many times I've gone into somebody's room and I said, oh, okay, do you wear glasses? Yeah, I do. They're over there, right? And they don't put them on. And it's like, okay, well, let's put them on. And they are filthy because they never clean them. And then they say they don't bother wearing them because they don't really help. And it's like, well, when was the last time you went to the eye doctor? I don't know, 5, 6 years ago. Chances are you need another visit to the eye doctor, right? So just making sure that they are able to do that. And then what we're going to do, it says role of therapy. This is, obviously I'm a therapist, but this is something anybody can do, right? It's that adaptation and compensation is what we're really looking for because we can't fix their eyes, but we can adapt the environment and we can help them compensate for what they've lost, right? So that's what's going to get the maximum participation. And it kind of does need to be a holistic approach to some of this. So maximize the lighting. We talked about that, right? More is not always better, but the appropriate kind, right? Increasing contrast. That can be really, really helpful. We'll go through a few of these items individually as well here. So hang on for that. Increasing the size or magnification, reducing glare, tactile input, auditory input, and getting the environment organized. So lighting, as we talked about, right? Different bulbs, those kinds of things. LEDs used to be really expensive. They've come down a lot in price. If you can find those ones that have the multiple adjustments in them, you can buy one set and put them in somebody's, thing, try a bunch of different settings, find what works for them, go get that exact bulb and replace it and keep your trial bulb to keep using over and over again, right? In different places. Decorative shades can actually be detrimental to the lighting, right? So making sure that that's adjusted correctly. Task lighting, right? Multi-directional, is it adjustable? Can they move it to where they need it? What's going to work best for them in that regard. Contrast, all right? Sometimes we like to do things and make them look really pretty, okay? Okay, that's great. But are we keeping in mind what the contrast is for those things? So you can see, like this gauge, this blood pressure gauge, I think it is, or heart rate monitor, maybe. Um, it's kind of black on white kind of look. That's like the greatest color contrast that you can get. It's the most easiest to see, right? Black letters on a white background. Okay. If you want to get a little creative, you can always utilize a color wheel, right? And you can Google that. Any color that is directly across from each other in a color wheel would provide great contrast. Some can be really ugly. You got to be selective, right? But putting black letters on an orange piece of paper for Halloween may be really hard for people to read. Okay, so we have to kind of keep that in mind. All right. The plates for meals and things like that. Um, it kind of goes along. It's not really part of low vision. It's a little bit more into the realm of I don't know, quality of life, I guess, or other factors. But colorful meals attract attention and stimulate appetite. There's been research to show that. So having meals that are colorful in nature um, actually can engage people a little bit more with their meal consumption. Okay. Now, we always talk about bright colored foods being healthy because that's kind of a vegetable thing, right? All those fruits and vegetables, which are important. But still, at that same time, having something that is visually appealing, right? If you talk to most chefs, they will say that people first eat with their eyes and then with their mouths, right? So color, you know, that helping that contrast as well. Magnification is probably one of the biggest things that you can provide somebody, right? And there are a slew of different magnification tools that can be used. Some very, very inexpensive to really pricey. I mean, I've seen ones that are actually book readers that will project the book up on a large screen. Um, can be a little prohibitive for a lot of people. Handheld magnifiers can work very well. Top of the list there, top of that picture is basically a pair of readers. That's what I have, and that helps me, and that's enough. You can get those fairly powerful, and I don't go to the optometrist for my readers. I go to Amazon and I buy them in a 5 pack because I will inevitably lose them or break them. So I don't go for anything fancy or expensive, and they work great. Handheld magnifiers also really work. There are some I've seen them that are basically look like a credit card. You just kind of unfold it and you can read a menu or something like that. And that's probably one of the biggest areas that can be helpful for a lot of people, just increasing the size of the font. I will say that I have done on many occasions, taken my cell phone, taken a picture of something so that I can then enlarge the picture. Okay. If I need a part for my refrigerator that broke and I cannot read that stupid label, I will take a picture of it and I will enlarge it. And then I can read the numbers off of it. So magnification in a lot of different ways. Controlling glare is really important, right? Um, I had this conversation many, many years ago it was a skilled nursing facility in one of those kind of institutionalized looking facilities, right? It's a great facility, but it's an old school. It's been around for a long time. And they just cleaned and polished the floors. And I was like, this was like really, really bad. They I got called in and asked to basically do an assessment to figure out why they were having so many more falls in the building. And first thing I saw was the floors being really bright and shiny. I said, "Oh, those are really bright. Oh, we just had somebody come in, they stripped them and they polished them." I'm like, I'm afraid you're going to have to kind of restrip them and put on a matte finish. I know it doesn't look as clean because it's not as bright and shiny, but it's creating too much glare and people aren't to be able to discern where the thresholds are. And you just watch people walking around in the hallways as they're trying to step around things and they couldn't see where they were going. So glare is a big issue for people. I have noticed a change in my ability to process glare already. I can't imagine what it'll be in another 20 years. Okay. There are some lenses that will help with that. You see the bottom picture there. I actually do have a pair of driving glasses that I leave in the car. They have special lenses on them that actually help reduce glare. Believe it or not, those glasses actually also help when it's raining because the light will refract through the droplets of rain and create kind of a glare scenario, And you put those glasses on, it's not like the rain's gone away, but it is actually then easier to see. All right. So some people may need something of that nature, but sometimes it's just adjusting the angle of the light coming in, so that it's not reflective off of a surface, right? Or sometimes softening the light itself. Tactile input can be really, really important. You think about that, right? People who are blind or have such significant low vision that they would be technically classified blind. By the way, you can still see and be classified as blind. Um, it's just a very low level, they can read Braille, right? Well, maybe we don't need to do Braille, but if somebody is using, in this case, there's a microwave and they're typically using the same settings, right? You can put some kind of tactile sense on that, on the buttons so that they know where those things are located. We've done this many times with a laundry machine, right? You have the indicator, the dial, right? And it has an arrow, but you can't see the arrow. So you put something raised on that. Believe it or not, sometimes as simple as nail polish, because that can be raised. Um, and you can feel where that is, and then they usually set it to a particular setting, put a little bit there too. And then when they get those two things lined up and they can, just touch and feel them, then they know that they're on the right setting. And then another tactile, a bump or piece of Velcro, some sticky, dot or something like that. These things are easily available off of Amazon. Um, Put where the, start button is so they know where to push the start button, that kind of thing. These can be very easy. The other nice thing about them, though, is that you can get these also in bright colors and contrast colors so that you can, I mean, just again on Amazon, if you Google contrast tactile, or bumps or something even simple as that, a lot of times you can get ones that have nice, bright, easily seen, but also raised. And it's just sticky back and you just stick them on where they need them. And then auditory input, audiobooks are certainly very prevalent these days, easy to find. There are organizations that will provide talking books for free. A lot of libraries will have those available as well. There are talking clocks and watches that are available. Um, I don't want to say the first one, but the Google Home, because I have that first one that begins with an A, and if I say she's going to come to life on me. So it's really funny. I actually coach softball, and we have a girl on our team named Alexa, and then we have another girl on the team named Siri. So we can basically find anything we need by asking the two of them. Um, but those can talk. See, there she goes. Alexa, stop. Um, Liquid level indicators, those are just kind of a little more specific, probably not really something that you need, but they'll trigger an auditory sound if there's a leak or you're filling up the sink with water, you can set that so that it gives you an auditory sound when they've reached the right level, that kind of thing. Um, One of the things that's not on here is text to speech, right? A lot of cell phones will have the ability to actually speak what a text is and those kinds of things. And you can even speak the text so that you can reply. People will need help setting that up. I will say, as another little plug, that falls again within occupational therapy. Their scope of practice is teaching people how to utilize technology. Um, so if anybody's computer savvy or those kinds of things, it's usually not hard for most of us to figure out how to set those things, but people may need help in order to be able to do that. They may not even know it's available, right? So and then organization, and it's not your organization. This is organizing their environment again, right? Keeping pathways clear, organize the items they need for a task all together, right? If there are things that they need more frequently, organize it so that those are more accessible, and things that they need very infrequently are the ones that are stored further away, right? Um, largest furniture up against the wall so it's not out in the middle of the floor cluttering things up, right? Doors and doorways, sometimes contrast can be really, really helpful with that. Go back to that facility that I was helping with their glare. They painted the walls, the doorways, and the doors all the same color. It was kind of a light, nice, warm color, but to be able to discern then where the door is and then the doorway through the door, right, can be very difficult. So providing some contrast there can be really helpful so that people can see where the opening is and they're not tripping over or banging into the doorway. And then throw rugs can be really, really bad, right? Um, so just to wrap up here, I just want to give a last thought because I touched on this, but I want to talk about this cognitive loss component. And actually, Dr. Kit was letting me know that this has been a recent topic of discussion, which I think is really great. Um, when people have cognitive loss, and I will tell you that even if you're in an IL, 90% of your folks have cognitive loss. They don't have dementia because it hasn't progressed to that point yet, but there is some cognitive loss, and it will, depend on that grading of, how much, depending on, how they're doing. But there is a change to their visual field when they have cognitive loss, right? And this is not a change in the actual eye structure or eye function. It's a change in the brain structure of being able to process all of that information coming in. And so the brain starts to narrow down the input. It's still kind of there, but they just aren't able to pay attention to it because of the limited cognitive processes. So remember the video I did before? Here's the exact same one of somebody, see, and there's somebody who's jumping right out in front of somebody and doing the right thing, right? Getting in front of them to say hello. But that can be very startling to somebody because they kind of came out of nowhere. So we need to be very careful in our approach. And that's why it's important to know that cognitive level sometimes, that we got to know how to approach somebody. So in very mild cognitive loss, right? If something is presented to somebody low, and think about the food on their plate placed in front of them at a meal, about 30 inches, right? About 30 inches in a diameter of 30 inches, about 2 feet away, they'll be able to see that fine. Okay. If it's presented up high, then it's about 2 or 3 feet is the limit of their peripheral vision, is what this is saying. Okay. They're not, depending on how deep they can see, is really going to depend on their visual acuity, but how much of the peripheral they'll be able to see, it's going to be limited to about 3 or 4 feet. When they get into some moderate cognitive loss, we're really starting to look at shoulder width and only about 6 to 8, can be about 12 feet in front of them to be able to really focus on it. Things beyond that are visible, but they're blurry because they're not really kind of focusing in on that. They're paying a lot more close attention to what's immediately in front of them. And then you get into that advanced cognitive loss, you're kind of getting into more severe dementia here, right? The moderate's starting to border on dementia, kind of getting into that area. Advanced is getting into significant dementia. Really, 6 inches is about what they can focus on. Everything else of the world is too much for them to process, so they really limit it to about 6 inches. Okay. Okay. So that's all. That is my presentation, and I'm just wondering if anybody at this point has any questions. Um, and Dr. Kitt, would you like me to stop sharing my screen at this point or um, leave that up for now?
Mark, you can leave that up for now if you like, but audience that are in attendance, please don't feel free to raise your hand and or put your questions in the Q&A box, and Mark will answer those live. While you do that, audience, I want to just make sure there's a couple of things, Mark, you talked about. Again, I'll go back to you talked about how to kind of set up your room within your home or within your community, whichever. There were some really great tips that you talked about in there. LED lights, you talked about rugs that you can move, and several other items. Will you just go over a couple of highlights for that?
Yeah, certainly. I mean, as you mentioned, the LED lighting is really important. Being very careful about throw rugs. People do like to have their decorative items around, and that's fine. But there are ways to, I don't want to say adhere them down. We just did this. We got one of these washable rugs, and we have a hardwood floor, and the dogs are constantly pushing it and sliding it. So you can get these kind of sticky pads that you put in the corners of them, and they are removable, so you can actually reposition, but it keeps the rugs from sliding, which can be really, really helpful. I didn't mention this, but along those same lines, people's footwear can be really important. Um, do they wear, closed-toed shoes? Do they have a heel? Are they wearing those house slippers? How old are their shoes? So are the bottoms completely worn and are they slippery kind of thing? But getting back to the low vision, one of the things I didn't mention in their environment is shadow. I talked a lot about glare, but there's also a problem with shadow. So having even lighting throughout the environment can be really helpful. But if you have all the lighting is set up, it's wonderful. They can sit in that chair and they can read. But then when they get up to go to the bathroom, once they pass the bookcase, there's a shadow that's being cast, and now they miss the doorway because their low vision made them not be able to see that very clearly. So looking at that, and I guess one of the things that I really stress with this is you can't look at it and say that looks good to me,
Right.
okay? Because we're not in their situation. We've got to look at it and go, well, I do see a shadow, so probably really bad for them. Or it's only a little bit of glare, which means there's a lot of glare for them. All
Right.
right. So we kind of have to take that into account when we're looking at it. It doesn't have to work for us. It has to work for the, I know, and I know you know that. I'm not trying to say
Mm-mm.
that.
No, it's good to share because we have everyone on this platform. So those are really good talking points, Mark, and really something we can do simply at home to make it safe now. Because
Right.
I chuckled, probably everybody saw me when you talked about having your readers. Yes, I too have my readers now.
Hmm.
So I think that's a common conversation that everybody should wear a magnifying glass. You had those tools. But then you had a really good tip about just using your smartphone sometimes,
Hmm.
taking a picture to make something bigger. The next question I have from the audience is, you talked about auditory and tactical
Hmm.
and how important those little things are. And you shared some tips about things that you can make a home safe with if you have low vision with some tactile.
Hmm.
Can you share some of those tips again, just highlights for the audience?
Yeah, I mean, think about in terms of safety, if somebody is using the stove, um, set it, and do they know if it's turned off? You don't want them to have to touch it to find out that it's turned off correctly. And what is their type of stove? Do they have a dial on it? Do they have push buttons? A lot of our stuff, I mean, our stove, our microwave, it's all push buttons. There's no dials or anything anymore. So if they type of person who loves to bake and they're going to bake a cake and it's 375 degrees, but they accidentally hit broil at 500, and then they reach in thinking that it's not going to be hot, or anything like that can be really significant. So just adding some kind of um, to make sure that they actually did hit the button to turn it off, I think is probably one of the big things, right? Many stoves will have an, an audible beep when you push a button. Some of them can be turned off. Sometimes they can be turned off on their cell phone so that they're not hearing that. So just making sure that those are set correctly, and then adding just a felt dot to the right button to make sure that they're hitting the right things instead of I thought I turned it off, but I actually turned on broil instead. And now my oven is 500 degrees for 3 days because I didn't realize it was on. Um, but even, the temperature of the water coming out of their faucet, is most faucets don't have any kind of indicator for that. So do they have a handle or do they have knobs? And if they have knobs, Do they know when it's all the way on, which is
Mhm.
hot, which is cold? Just simple things like that. Just thinking those things through, looking at their environment and saying, you know, well, I would be able to handle that again, but that could be a point of an issue, or um, the edges of the stove, do they need something that indicates where that is? I mean, maybe a lot of the residents are not using the stove and that kind of thing, but um, drawers, that maybe they can be labeled better with
Mhm.
something raised. I know that the one dot is the knives and the two dots are the forks. Something simple as that a lot of times. And it can sound kind of silly, but yes, there's a safety concern, but there's also really a quality of life concern. These people want to be able to take care of themselves. They don't want to always have to ask for help, which leads to a safety problem because they may try to do it on their own without asking. And so giving them some of those really simple and subtle, because they don't have to be really
Right.
big and, labeled and, all these things, but just
Hmm.
sometimes subtle dots that they can go, I know where everything is and I can find this on my own now, instead of doing something that maybe puts them in a compromised position.
Thank you, Mark. You have shared the importance of ensuring that we help people with low vision have an excellent quality of life and making sure that they are safe. So, thank you for presenting today. Thank you for being one of our presenters coming this next year. Thank you to the audience for attending today and your wonderful questions. And we will see you on our next RUI Informed, where we will talk about the benefits of retirement along with some safe tips on how to invest wisely. We'll see you then. Thank you, Mark. Have a good evening, everyone. Bye bye.
Bye bye.